इसमें नाम लिखना है। आज क्या डेट है? 20 है आज।
नहीं 18 है।
18 है। तो बच्चे दिखेंगे भी मुझे। शुरू करो ना। यहाँ बैठती क्लास में। चेहरा नहीं आ रहा।
अभी बच्चे आए नहीं है।
अच्छा कोई बच्चे ही नहीं आए?
अभी
आते हैं ना बच्चे। बस मैं बच्चों को नहीं देख पाऊंगी। हाँ
हाँ
ये ऑडियो वीडियो वीडियो तो होगा, ऑडियो इतना ख़राब आएगा।
एसी चल रहा है।
अच्छा तो सुनाई नहीं देगा, उन्हें बंद कर दीजिए इसे। कुछ बेटर हुआ? हाँ थोड़ी शांति तो है। लेकिन बहुत लेट बोल रही है, जैसे मैं बोल रही हूँ तो उसमें
20 सेकंड का फर्क है। 15 से 20 सेकंड।
बच्चे आएंगे तो उसमें आ जाएगा ना, यूट्यूब में।
हाँ।
So students, today we are going to have a class on puparium and its complications. So beginning, the puparium is derived from the Latin word pure, means child, and paris means bringing forth. So it is the time following delivery during which pregnancy induced maternal anatomical and physiological changes return to the non-pregnant state. It is also referred to as the fourth trimester of pregnancy. It lasts for about 6 weeks after delivery, and immediate puparium is the time within the first 24 hours of parturition. Early puparium is the time till 1 week postpartum, and remote is till 6 weeks postpartum. So what are the normal changes which occur during normal puparium? So all the organs which had undergone changes for pregnancy, they revert back to their normal size. So the vagina and the outlet gradually diminish in size and rarely regain the nulliparous dimensions. Vaginal rugae reappear by 3 weeks. The hymen is replaced by tags of tissue called myrtiformis carunculus. Vaginal epithelium proliferates by 4 to 6 weeks, and perineal lacerations heal in 14 days postpartum. The cervical opening also contracts slowly, and for a few days immediately after labor, it readily admits 2 fingers. By the end of the first week, the opening narrows and the endocervical canal reforms. The external os, however, remains wider, and the ectocervical depressions at the site of lacerations become permanent. So you can see the nulliparous cervical os with round os is present if she has not given birth, but after birth the parous cervix is in the form of a transverse slit. So uterine involution involution is the process by which the uterus regains its normal size after the delivery. So, immediately after delivery it is around 20 weeks of gestation, 20-week size of uterus. After 1 week it decreases to 12-week size. In 2 weeks it becomes a pelvic organ and is not palpable, and in 8-week size it reaches the pre-gravid state. So, in uterus the larger blood vessels get obliterated by hyaline changes, they get resorbed and replaced by the smaller ones. The size of the myocytes decrease but not their number, and during the next few weeks lower uterine segment is converted into uterine isthmus, and after each pregnancy the uterus becomes larger than the normal. So, now coming to the endometrial changes, the superficial layer becomes necrotic and is sloughed as lochia, and the basal layer adjacent to the myometrium is the source of new endometrium, and lochia is the vaginal discharge for the first 15 days following pupurium. So, it is divided into 3 types: lochia rubra, serosa and alba. Rubra, as the name indicates, is dark red in color and it lasts for about 3 to 4 days, and the red color is because it is mainly made up of blood, bits of fetal membranes, decidua. And lochia serosa, it is pinkish brown in color and it lasts about 4 to 10 days. It contains less of RBC but more of WBC, wound discharge from the placental and the other sides, as well as some mucus from the cervix. While the lochia alba is whitish yellow in color and it lasts 10 to 28 days, and it is mainly composed of the decidual cells, mucous cells, white blood cells and the epithelial cells. What is the clinical importance of lochia? If the lochia is very foul smelling, maladress, that means that the patient is also having fever, then it is indicative of puerperal sepsis. If the lochia is totally absent or scanty, then either there is obstruction in the form of lochiometra or there is some infection. Excessive lochia is also indicative of infection. Red colored lochia is because of the subinvolution of the uterus, which can occur because of the retained products of conception and can lead to secondary postpartum hemorrhage. If lochia alba persists beyond 4 weeks, that indicates local genital infection. Now, the uterus, cervix and the vagina, they undergo changes to become normal. Similarly, the urinary tract also goes back to its normal physiological size and shape like earlier. So, the glomerular hyperfiltration returns to pre-pregnancy state by 2 weeks. The dilated ureters and the renal pelvis return back to normal by 2 to 8 weeks. Postpartum bladder has an increased capacity and relatively insensitive to intravesical pressure. So, the patients can have problems of over-distended urinary bladder, sense of incomplete emptying or excessive residual urine are frequent in post-pupurium patients. The abdominal wall remains soft and flaccid. Several weeks are required for these structures to return to normal. Recovery is aided by exercise, and except for striae gravidarum, the abdominal wall resumes its pre-pregnancy appearance. Now, coming to the hematological changes, leukocytosis up to 30,000 can be normal, and it is predominantly because of the granulocytosis, and thrombocytosis may also occur. There is lymphopenia and eosinophenia. Hemoglobin and the hematocrit values, they fluctuate moderately, but the fibrinogen levels increase in the first week postpartum, and this predisposes women to increased risk of deep vein thrombosis in the early pupurium, and all these changes normalize by 5 to 8 weeks of postpartum period. Coming to the cardiovascular changes, at 1 hour postpartum, both the cardiac output and the stroke volume remain increased, and the patient is at increased risk of congestive cardiac failure in this phase, because whatever supply to the uterus was going is stopped after the delivery, and this goes back to the heart, and this may lead to congestive cardiac failure in patients who already have heart disease. So, cardiac output remains elevated for 24 to 48 hours postpartum, and this declines to non-pregnant values by 10 days. So, need to remain vigilant for the 24 to 48 hours postpartum. Heart rate and the blood pressure return to non-pregnant values by 2 to 6 weeks respectively. If the patient is not breastfeeding, then menstruation usually resumes in 6 to 8 weeks time. But if the patient is breastfeeding, then ovulation returns by 10 weeks. If she is not breastfeeding, then it can return as early as 4 weeks. Now, coming to the breastfeeding and lactation, you can see that there are a number of myoepithelial cells and alveoli and the ducts. So with the oxytocin, the muscle cells gets contracted, and the contraction leads to ejection of milk into the ducts. And while prolactin hormone, this makes the milk secreting cells secrete hormone. So for the first 5 days to 2 weeks, there is colostrum, secretion of colostrum, which is rich in IgA, complement, macrophages, lactoferrin and lactoperoxidase and lysozyme, and all these are very important for providing the immunity to the newborn, and this changes to mature milk by 4 to 6 weeks. Vitamin K is absent in the mature milk, and vitamin D content is very low, 22 international unit per ml. So infants who completely breastfeed or partially breastfeed should receive 400 international unit of vitamin D supplementation. There are some contraindications to breastfeeding when the breastfeeding woman, if she is on street drugs, has excessive alcohol uses, or if the infant is having galactosemia, or if the patient is having active untreated tuberculosis, or is on some anti-cancer drugs, then she should avoid breastfeeding the newborn. If for hepatitis B infected patients, if the immunoglobulin is given to the newborn, breastfeeding is not contraindicated. For hepatitis C, breastfeeding does not transmit the infection, but in the presence of active herpes simplex lesions on the breast, then breastfeeding should be avoided. But if there are no breast lesions, then breastfeeding is not contraindicated. Mothers who are seropositive for cytomegalovirus can breastfeed. Now, is HIV a contraindication to breastfeeding? Ideally, breastfeeding does lead to transmission of infection, transmission of HIV infection, but exclusive breastfeeding is recommended for the first 6 months, irrespective of whether mother or the infant is provided with ARV drugs during the duration of the breastfeeding, because the benefits outweigh the risks. Milk feeding should not be prescribed, and only in situation where breastfeeding cannot be done or on individual parents' informed decision, replacement feeding may be considered. Exclusive breastfeeding should be done for at least 6 months, and complementary feeding should be introduced gradually, irrespective of the infant being diagnosed with HIV positive or negative. So ARV prophylaxis should continue for 1 week after the breastfeeding has fully stopped. Now, what are the advantages of breastfeeding? It protects the infant against diarrhea, respiratory tract infection, necrotizing enterocolitis, otitis media, bacteremia, UTI, and so many advantages of breastfeeding. Not only the baby, but the mother has also advantages, like it leads to decreased postpartum bleeding and more rapid uterine involution, decreased menstrual blood loss and increased child spacing, earlier return to the pre-pregnancy body weight occurs, and also there is decreased risk of breast and ovarian cancer. So all women should breastfeed until unless there are certain contraindications to breastfeeding. So we should advise the woman about how to do the breast care and what is the proper method of feeding. She should wash the areola with soap and water before and after nursing. Ensure proper attachment and method of feeding. This is the diagram showing the correct latch-on method. The mouth should be widely open, and the areola should be completely covered by the mouth, and the lips are flanged out. Expressing excess breast milk should be done to avoid the breast engorgement. Now, perineal care is also important. All women should be advised to clean the vulva from anterior to posterior. If there is edema and discomfort, cool packs can be applied. Severe perineal vaginal rectal pain, it warrants careful inspection and palpation. Severe discomfort, if it is present on the first day, then hematoma should be ruled out, and if it is present on third and fourth day, then infection should be ruled out. Hot sage bath and Kegel exercises should be patients should be told about these exercises. And we have the pelvic floor exercises, where the woman will squeeze her anus, and this will lead to toning of her pelvic floor. Is same way she can go for abdominal exercises, and all these exercises have been proven effective in reducing urinary incontinence as well as preventing the postpartum pelvic organ prolapse. Now coming to the common problems in the normal puperium. The first is after pains. After pains are the myometrial contractions which assist in involution. It is more common in multipara than primigravida. They decrease in intensity by third day and they sometimes increase in intensity when the newborn suckles because of the release of oxytocin. Usually we don't prescribe any analgesics, the counseling can help, but if the patient is excessively complaining about the after pains, then we can give her analgesics. For cracked nipples, it can be because of local unclean hygiene, retracted nipple or incorrect attachment of the baby, and the patient will complain of pain on feeding, and the treatment is proper attachment and maintenance of the hygiene. If the nipples are fissured, emollients and nipple shields are recommended for 24 hours or longer, and if the fissuring is severe, newborn should not be permitted to nurse on the affected side and empty the milk regularly until the lesions are healed. Now, for postnatal care of mothers and newborns, we have WHO recommendations, and they have given us guidelines for timing of discharge from the health facility after birth. And so, after an uncomplicated vaginal birth in the health facility, mothers and newborn should receive care in the facility for at least 24 hours. And if the birth occurred at home, then postnatal contact should be as early as within 24 hours of birth. After this, 3 additional postnatal contacts are recommended. First, one on day 3, another on day 7 to 14, and last one at 6 weeks. Home visits for postnatal care, one in the first week of birth, and in those visits, assessment of the baby should be done. Family should seek health care if they identify any of the following danger signs in the baby, like the baby has stopped feeding well, there is presence of convulsions, if the neonatal respiratory rate goes more than 60, there is severe chest indrawing, there is no spontaneous body movement, or if the baby is running fever or jaundice in the first 24 hours of life. Exclusive breastfeeding should be done from birth till 6 months of age. And for the cord care, daily chlorhexidine application to the umbilical cord stump during the first week of life for the newborns who are born at home in settings with high neonatal mortality. But for the hospital born infants, we need not do this application. Bathing should be delayed until 24 hours of the birth. This is for the newborn, not for the woman. And postpartum women should be encouraged to take bath, ambulate, and return back to their normal activity gradually. Appropriate clothing should be given to the newborn according to the temperature of the environment. Mother and the baby should not be separated, and baby should be fully immunized. Assessment of the mother in the first 24 hours. Regular assessment should be done for the vaginal bleeding, uterine contractions, bundle height, temperature, and the pulse rate. Blood pressure should not be measured shortly after delivery. If normal, the blood pressure should be measured shortly after delivery, and if normal, then the second BP measurement should be taken within 6 hours. Urine should have been voided within 6 hours of delivery. Beyond 24 hours, assess the urination and urinary incontinence, bowel function, and healing of the perineal wound, uterine tenderness, and lochia. At 10 to 14 days after birth, all women should be asked about mild transitory postpartum depression. All women should be asked about resumption of sexual intercourse and possible dyspareunia as a part of assessment of the overall well-being 2 to 6 weeks after birth. All women should be counseled on nutrition, hygiene, birth spacing, family planning, and contraception, and they should be given at least 3 months of iron and folic acid supplementation so that they regain their pre-pregnancy hemoglobin status. Use of antibiotics in vaginal delivery with 3rd or 4th degree perineal tear is recommended, but not in uncomplicated vaginal deliveries. And of course, the psychosocial support is very important, especially in women who are at high risk of developing this condition. Now coming to abnormal puperium, we have a range of problems in abnormal puperium: P sepsis, subinvolution, secondary PPH, venous thromboembolism, breast related complications, and the psychiatric disorders. And the first one which we are going to discuss is the puerperal pyrexia. So any rise in temperature that reaches 38 degrees centigrade or more on 2 occasions at 24 hours apart within the first 10 days following delivery is P sepsis. Puerperal pyrexia, and mostly it is because of puerperal sepsis, which is the infection of the genital tract any time between the onset of rupture of membranes or labor and the 6 weeks postpartum. So Two or more of the following features can be present in patient with P-sepsis: pelvic pain, fever, abnormal vaginal discharge, foul smelling discharge, and subinvolution of the uterus. Severe sepsis is sepsis plus sepsis induced organ dysfunction or tissue hypoperfusion, and septic shock is defined as the persistence of hypoperfusion despite adequate fluid replacement. Now, what are the different causes of puerperal pyrexia? It can be because of mastitis, urinary tract infection, pneumonia, skin and soft tissue infection, gastroenteritis, pharyngitis, and infection related to regional anesthesia. And the risk factors for maternal sepsis are obesity, impaired glucose tolerance and diabetes, impaired immunity, anemia, vaginal discharge, amniocentesis and other invasive procedures, cervical cerclage, prolonged spontaneous rupture of membrane more than 18 hours, vaginal trauma, cesarean section, wound hematoma. All these predispose women to maternal sepsis. So what happens that but the pathology of endometritis is like there is normal flora and the cervicovaginal bacteria which gets breached because of the cervical examination, internal monitoring or prolonged labor or uterine incision in the form of cesarean section. This leads to inoculation of bacteria into these environments, and in the presence of anaerobic conditions like surgical trauma, sutures, devitalized tissue, blood and serum, there is clinical infection which leads to bacterial proliferation, and this leads to puerperal infection. So what are the clinical signs of puerperal sepsis? The patient will have fever, hypothermia, tachycardia, tachypnea, hypoxia and hypotension, oliguria, impaired consciousness, and there is failure to respond to initial treatment of sepsis. So the red flag signs are when the fever is more than 38 degrees centigrade, tachycardia is more than 90, breathlessness is more than 20, there is diarrhea and vomiting, there is uterine and renal angle pain, and woman is generally unwell or seems unduly anxious or distressed. So the blood culture is the key investigation, but it is not necessary to wait for the blood cultures prior to the antibiotic administration, because giving antibiotics as soon as the patient approaches is life saving. Serum lactate should be measured within 6 hours, and if it is more than 4 millimoles per liter, then this is indicative of tissue hypoperfusion. Relevant imaging should be performed like chest x-ray, ultrasound pelvis and CECT if the pelvic abscess is suspected. Other samples should be guided by the clinical suspicion and focus of infection. Routine blood investigations like CBC, electrolytes and CRP should be done. In women with pharyngitis and tonsillitis, throat swabs also should be sent for culture. So the most important test is the blood culture. However, you may not need for the blood culture report prior to before antibiotic administration. You should prescribe the antibiotic as soon as the woman reaches the health facility. Administration of IV broad spectrum antibiotics within 1 hour of suspicion of severe sepsis with or without shock is recommended. If the genital tract sepsis is suspected, early treatment with IV broad spectrum antibiotics is life saving, and a combination of piperacillin tazobactam and a carbapenem clindamycin provides one of the broadest ranges of treatment of severe sepsis. Excuse me, I have to attend a call. Hello? I'm in class. Okay. So the combination of piperacillin tazobactam or a carbapenem clindamycin provides one of the broadest ranges of treatment of severe sepsis. If it is likely to be MRSA positive, a glycol peptide such as vancomycin or a teicoplanin may be added. So the indications for admission of a postpartum woman in ICU are if the woman has hypotension and raised serum lactate, if she is developing pulmonary edema and requires mechanical ventilation, if the patient develops acute kidney injury requiring renal dialysis, or if she has neurological manifestations in the form of significantly decreased consciousness level and there is multi-organ failure with hypothermia and uncorrected acidosis, then these warrant admission into the ICU. Now, because of endometritis, there can be several sequels. The inflammatory process from the endometritis with necrotic yellow-green endometrium, it extends into the wall of the uterus. Okay, it can extend into the parametrium and may cause pelvic cellulitis and peritonitis. Okay, or it can lead to involvement of the adjacent blood vessels and can result in septic pelvic thrombophlebitis and severe induration in the parametrium. This can develop into parametrial phlegmon, or sometimes a pelvic abscess can develop as a sequel of endometritis. So now coming to subinvolution. Subinvolution, when the rate of involution of the uterus is not according to what is prescribed. Like immediately after delivery, the uterus will be around 20 weeks of gestation, and within the 24 hours the uterus remains static, but it decreases at the rate of ½ inch per day. So daily on rounds you should have an inch tape and measure the symphysosphincteral height and see the rate of involution of the uterus. The risk factors are risk factors for subinvolution. It can be either because of antepartum factors like anemia, malnutrition, or uterine overdistension because of multiple pregnancy or polyhydramnios. Intrapartum factors like prolonged or obstructed labor, operative vaginal delivery, prolonged rupture of membranes, and postpartum hemorrhage, or postpartum factors like retention of certain products of conception and pelvic infection. These risk factors can lead to subinvolution of the uterus. And how will the patient present? What patient will complain of? They will have prolonged lochial discharge with irregular or excessive uterine bleeding along with abdominal cramping and fever. And on bimanual examination, the uterus will be very larger and softer than what is expected. The treatment is antibiotics to prevent endometritis and adequate hydration. If there are retained products of conception on ultrasound, exploration of the uterine cavity should be done, and a vacuum evacuation and check curettage should be done under ultrasound guidance. And sometimes methyl ergometrin 0.2 milligram orally every 3 to 4 hours for 24 to 48 hours is also recommended. Now coming to the breast related complications. So if there is engorgement, breast engorgement, the engorged breast become full, hard and sore, and this pressure can cause damage to the cells, and the patient will have extreme difficulty in feeding the baby. So for managing such patients with breast engorgement, we advise tight breast support, ask them to apply cold packs, and oral analgesics can be provided for 12 to 24 hours, and the breast needs to be emptied either through manual expression or through the breast pumps. Now for inverted nipples, like this is the normal nipple, this is flat nipple, and the inverted nipple where the nipple has not yet come out of the areola, for them the nursing is difficult and milk can be drawn out from them by a breast pump. And antenatally we should examine the breasts of the woman and rule out inverted nipple and ask them to tease the nipple out with fingers during the last trimester of the pregnancy. These polythelia and polymastia, they don't have any obstetrical significance, and they can cause occasional discomfort during pregnancy and postpartum due to engorgement. Galactocele, where there is excessive enlargement of the breast, it can cause pressure symptoms, but it resolves spontaneously or sometimes may require aspiration. Now coming to breast infections, mastitis, that is the infection of the breast, is mostly because of the Staphylococcus aureus, which is MRSA, and the patient will have fever with chills and tachycardia. The patient will complain of severe pain and the breast becomes hard and red, and 10% of the women with mastitis, they may develop abscess. And symptoms of suppurative mastitis appear usually in the 3rd or 4th week postpartum, when the milk secretion has started fully. So for management of mastitis, we need to give antibiotics. Dicloxacillin 500 mg QID is started empirically. Erythromycin can be given to penicillin sensitive patients. Resistant organisms are suspected when, if resistant organisms are suspected, vancomycin and clindamycin are given, and supportive measures can be given. If it is not treated, then it can lead to breast abscess, necrotizing fasciitis, and toxic shock syndrome. If mastitis has progressed to the stage of breast abscess, then what we need to do is to provide support to the breast, local heat and analgesics for relief of the pain. Incision and drainage is to be done if infection do not resolve within the 48 hours of antibiotic therapy. Usual incision is radial over the affected segment, and circumareolar incision is preferred if it allows adequate access to the affected area. Incision should pass through the skin and the superficial fascia. Long artery forceps is inserted. You can see this is the long artery forceps. This is inserted and all the loculi are felt, and finger is introduced and the remaining septa are disrupted, and then it is packed with some roller gauze, and a drain is inserted to allow the dependent drainage. Now coming to the most important and life-threatening complication of pupurium, that is secondary postpartum hemorrhage. It is the excessive bleeding that occurs between 24 hours to 12 weeks after delivery, and mostly it is because of retained products of conception which get infected, or it can be because of uterine AV malformations or any bleeding disorders or gestational trophoblastic disease. So the management is, we should admit the patient, start them on broad spectrum antibiotics after taking the blood cultures and high vaginal swab for cultures, do an ultrasound scan to rule out retained products of conception, ask for coagulation tests along with the CBC, LFT, KFT, and then what we need to do, if in a hospital without specialist, we should do a general resuscitative measures before transferring the patient. Give her, if the patient is excessively bleeding, then syntocinon should be given 40 internationate in 500 ml at the rate of 20 drops per minute. IV methergine can be given, and resuscitation should continue while during the transit of the patient to the tertiary care center. Adequate resuscitation with blood transfusion should be done to correct anemia. IV antibiotics should be started as soon as possible, and it should be continued till the woman is afebrile, and then change it to oral antibiotics for 5 days. If there are products of conception after 6 to 8 hours, then exploration and evacuation of the POCs should be done. If the bleeding is excessive, consider emergency examination under anesthesia and evacuation after adequate resuscitation and initiating antibiotics therapy. So for management of secondary postpartum hemorrhage, you must remember it throughout for whole of your life that it is because of retained products of conception which get infected. So as soon as the patient comes, resuscitate the patient, give her fluids, send her CBC coagulation profile, give her blood and blood products, do an ultrasound to rule out retained products of conception, do a PV examination, give syntocinon, and if there are retained products of conception, then evacuate it if the patient does not respond after 6 to 8 hours of antibiotic therapy. So now coming to venous thromboembolism, either it can be deep vein thrombosis or it can progress and lead to pulmonary embolism, and you all know why purpurium is why there is increased risk of venous thromboembolism during the purpurium, because of excessive increase in fibrinogen level and other coagulation parameters in the post purpurium. The patients with deep vein thrombosis, they have swelling, unilateral swelling and tenderness, and erythema with increased skin temperature and edema, and there will be positive Homan signs, that is when you suddenly dorsiflex the feet, there will be pain in the calf, and there can be positive Moses sign, that when you squeeze the calf muscle, then the patient will have tenderness. With patients with, if they have pulmonary embolism, the patient usually present with dyspnea, chest pain, hemoptysis, and they may also have signs and symptoms of DVT, and the classic sign of massive embolism is sudden collapse with chest pain and air hunger. So investigations are compression complex Doppler ultrasound of the lower limbs, MRI imaging, CTPA and ventilation perfusion scintigraphy or the lung scan. And management is, the treatment with low molecular weight heparin must be started. For massive pulmonary embolism, unfractionated heparin must be started. Other procedures like thrombolysis and surgical measures can also be used if the patient does not respond to heparin. And for postnatal patients, we categorize the patient into high risk, intermediate risk and low risk. And for high risk patients, like any woman with previous venous thromboembolism, anyone requiring antenatal low molecular weight heparin, or high risk thrombophilia or low risk thrombophilia or genetic thrombophilias, in those patients we should prescribe heparin for at least 6 weeks. Low molecular weight heparin is usually given. And for the low risk woman, we can prescribe early immobilization and avoidance of dehydration as a prophylactic measure. And in between the two, for the intermediate risk, we provide postnatal prophylactic low molecular weight heparin for at least 10 days. And these are the intermediate risk factors when the cesarean section was done in emergency, BMI was more than 40, or if the patient requires readmission or prolonged admission for more than equal to 3 days in the puparium. So these are the RCOG guidelines according to which we manage the patients. Sometimes there can be neuropathies when the pressure on the branches of the lumbosacral nerve plexus during labor occurs, and this manifests as intense neuralgia and the cramping pains. If the nerve is injured, pain may continue after delivery. Sensory loss or muscle paralysis can result. Sometimes food drop can result secondary to the injury of the sciatic nerve or the common peroneal nerve. The risk factors for neuropathies are nulliparity, prolonged second stage of labor, or pushing for long duration in the semi-Fowler's position. Sometimes the woman may also complain of bowel problems during labor in the puparium, and this can be because of lack of fluid and food during the labor or dehydration during labor. All this can lead to constipation which may continue in the puparium. Advice should be offered to increase the intake of fluid and fibers in the diet. Osmotic laxatives such as lactulose can be helpful, and women in 3rd and 4th degree perineal tears should be prescribed stool softeners and laxatives. Urinary tract infections are also common in the puparium, and they are mostly because of the gram negative organisms, and cefotaxime plus gentamicin OD is given, and we send midstream urine sample for urine culture and urine routine and the culture, and antibiotics can be prescribed according to the growth. Now coming to the postpartum psychiatric disorders, it includes postpartum blues, depression and the psychosis. And the postpartum blues are also known as baby blues, and the prevalence is as high as 50 to 80%. The patient will have transient rapid mood shift, tearfulness, anxiety, irritability, insomnia, lack of energy and loss of appetite. But these symptoms do not interfere with the mother's ability to function or care of the child. Usually the onset is in the postpartum day 3, which peaks on day 5, and it gets resolved by the 10 days. 20 to 25% of women with postpartum blues excuse me, progress to postpartum depression, and the treatment is education, reassuring and family support. Now postpartum depression, the prevalence is 15 to 20%, and it can occur up to 1 year of childbirth, and it starts with the symptoms of postpartum blues but do not resolve within the 2 weeks, and they become more severe. It is because of profound hormonal changes occurring after delivery, and 50% of these women who develop postpartum depression, they are at risk of developing depression in the subsequent pregnancy also. The risk factors are personal or the family history of depression, severe psychosocial problems, chronic interpersonal difficulties, marital disharmony, unwanted pregnancy, first childbirth or preterm birth, stillbirth, stressful life events and anxiety during pregnancy. So all these risk factors can predispose to postpartum depression, and the management ranges from psychotherapy to pharmacotherapy in the form of selective serotonin reuptake inhibitors, and the first line is SSRI, sertraline and fluoxetine can be provided. Start with the lowest effective dose up to 6 weeks. If there is no response, then we can add one more SSRI and refer to psychiatry. Postpartum psychosis, it occurs in 1 to 2 in 1000 women. Women with bipolar disorders are at high risk, but postpartum psychosis can occur in women with no previous psychiatric history also. There is dramatic onset emerging as early as the first 48 to 72 hours after delivery, and sleep disruption is one of the precipitating factors. It is a medical emergency and treatment should be given in the form of cognitive behavioral therapy, family intervention and pharmacotherapy. These are the drugs which are prescribed in women with postpartum psychosis, and treatment for 6 weeks should be given with close monitoring, and usually there is good prognosis if it is diagnosed early and treatment is started early. Easy to treat initially, but if left untreated and progresses to second postpartum years, then it becomes refractory to treatment. Now coming to postpartum contraceptives, we have a range of contraceptives starting from the intrauterine copper to devices to progesterone only implants, POPs, emergency contraception and even sterilization. So we need to prescribe the contraceptives according to the medical eligibility criteria. This is the MEC wheel, and it is like this. For the postpartum and the breastfeeding women, category 1, which is the safest, is copper T, then category 2 is LNG IUD, category 3 is DMPA. So we can prescribe the several contraceptives according to this MEC wheel. So postpartum contraception in the form of IUCDs, it can be given as early as within 10 minutes of the delivery of placenta, that is within the that is known as post placental IUCD insertion, and within 48 hours of delivery if we insert the copper T, then it is known as postpartum IUCD insertion. After 48 hours it should be avoided till 28 days of childbirth. Now injection DMPA although can be started immediately after delivery, but WHO MEC 3, it is category WHO MEC 3 until 6 weeks and MEC 1 after 6 weeks of delivery. Combined oral contraceptives in a breastfeeding woman should be prescribed only after completion of 6 weeks after childbirth, but in a non-breastfeeding woman it can be started as early as 21 days. In a breastfeeding woman, it has been seen to decrease both the volume and the quantity and the quality of the breast milk. So we should avoid giving combined oral contraceptive pills in a breastfeeding woman. Barrier contraceptives, they are safe after childbirth, but for the female barrier contraceptives, we should wait till 6 weeks for the uterus to return to the normal size. Now coming to lactation amenorrhea method, this is a very effective method of contraception, but it is 98% effective only if the women are less than 6 months postpartum, they haven't resumed their menses yet, and they are fully breastfeeding. Then only lactation amenorrhea method is the highly effective method of contraception with efficacy as high as 98%. So the risk of pregnancy is increased if the frequency of breastfeeding decreases, when the menstruation returns, and when more than 6 months of childbirth has already occurred. For immediate postpartum IUCDs, the expulsion rates are very high, as high as 10 to 27%. But despite high expulsion rate, it has superior value, especially for those who do not come for a recommended postpartum follow-up at 6 weeks of delivery. Emergency contraceptions in breastfeeding women, it is indicated after an unprotected sexual intercourse, and of course levonorgestrel 1.5 mg, LNG EC or ulipristal acetate 30 mg are safe to use from 21 days after childbirth. Copper IUCDs is safe to use for EC from 28 days after childbirth. Some women can also be, those who have completed their families, they can go for puerperal sterilization, and this can be done either through, for postpartum, it can be done through mini laparotomy, and by modified Pomeroy's techniques we can go for sterilization. So the take home message is that normal puerperium is completely physiological. Postpartum care is important for early detection and management of complications related to puerperium. Woman and child should be monitored in the hospital for the first 48 hours. Proper breast care, perineal wound hygiene, cesarean section scar care should be explained to the woman. Early and exclusive breastfeeding is advised to develop bonding between the infant and the mother. Lactation helps in contractions of the uterus, decreases the postpartum weight retention, and lowers the risk of breast and reproductive cancer. In mothers with HIV on ART, we should advise exclusive breastfeeding till 6 months and then introduce the complementary feeds. presence of fever 100° in the first 10 days following delivery, it indicates infection, and cause should be explored for proper management and avoid the complications. If the woman has past or a family history of mental illness, be alert for possible symptoms of postpartum psychosis in the first 2 weeks of childbirth. Comprehensive postpartum visit has to be scheduled between 4 weeks and 6 weeks after delivery. There is no need of contraception in the first 21 days post delivery. Thank you. If you have any questions, you can chat in the chat box.